Thank you so much. Good afternoon to all the colleagues and friends in the Eastern Mediterranean region, and also good morning and good evening to all the dear participants from other regions. It's a great pleasure to be with you today to discuss the Humanitarian-Development-Peace Nexus and its implementation in the health sector with examples and perspectives from the Eastern Mediterranean region. My name is Ali Ardalan. I'm a regional advisor in WHO EMRO, currently leading a Nexus-style unit named Health Systems and Emergencies Lab. I will be moderating the session today with my colleague, Dr. Clara Offen, who is based in Institute of Tropical Medicine in Belgium as a health system researcher while supporting EMRO as a consultant. In today's session, we are privileged to be with a group of distinguished experts. They will share with us their expert opinions and also experiences on the topic during the panel discussion as well as question and answer sessions. Dr. Abad Mataria is the Director of Universal Health Coverage / Health Systems in WHO EMRO and leading the health system development agenda in the organization in the region. Dr. Rick Brennan is a regional emergency director, and actually he's a global expert with vast experience on working on the different humanitarian settings worldwide. Dr. Iman Shankiti is the WHO representative in Lebanon with vast experiences of working in different countries in the region, including Afghanistan and Sudan, and now serving Lebanon. Dr. Anirban Katerji, that actually is the regional chief of health in the regional office of the UNICEF and has been working on the health programs with UNICEF for a long time at the regional level and also while supporting the country operations. Dr. Ayman Jarboui is the regional head of health and healthcare unit in IFRC regional office, and basically will bring the perspective of the community-based initiatives to the discussion. And last but not least, Dr. Egbert Sondrup, that he's the senior advisor of health system in Royal Tropical Institute of the Netherlands, a well-known expert working in different countries in our region and also worldwide. In this session, that the aim is to contribute to closing the knowledge gap that currently exists around the humanitarian development nexus and its implementation. We are pursuing the following specific objectives. We want to present the nexus approach using examples from the region, discuss the opportunities and challenges linked with the implementation and the ways that can be addressed, and also situate the nexus approach in the context of the COVID-19 and discuss how it can contribute both to effective health system response and recovery. We have 75 minutes in total, including this introduction, that after this slide, we'll have a Mentimeter exercise by Clara, followed by an introductory presentation about the Nexus approach to health. Then we'll have the perspectives from the panelists, and then basically asking your questions from the panelists in the QA, and finally the conclusion and wrap up. And during this time, I would invite you to please contribute in the chat box and add your comments and questions that we can review and group in some key questions and actually ask our distinguished panelists. Kilara, it is over to you.
Okay, so I'm going to share my screen. And I will ask everyone to go onto the Mentimeter site to use the code and to try to answer the question. I think we have about 3, 4, 5 minutes for this exercise, just so we can have an idea of where everyone is on the subject. I'm just waiting to see if people are responding, but I don't see any responses yet. Okay, good. They're coming up.
We need more response, please.
Okay, I guess we could give it 1 or 2 more minutes and then we can move on. I mean, we can already see a few things that come out strongly. Coordination, for instance, and then this gap, transition, addressing crisis, creating resilience, etc. Dr. Ali, perhaps we could move on, maybe. I will keep the screen shared.
Yeah, thank you so much. Actually, all relevant topics to the Nexus. I appreciate Kilara and also those participated into this exercise. So if I would again share my screen. Yes, so basically, before going to the panel discussion, that's just a kind of the quick overview of the humanitarian development piece nexus for health. Uh, the first question actually usually is that why this approach is needed. This is a kind of the consensus that improving health outcomes in complex and protracted emergencies requires a three-pronged approach that are responding to immediate needs, strengthening or rebuilding the health systems while preventing future emergencies. This is why work on each area is carried out by humanitarian development and peace actors traditionally that are working independently and in silos sometimes and use different work modalities and financial mechanisms. Yet activities in each part of the triad may have an impact on others, and that's why the coordination and complementarity between the different groups of the actors is needed. And the subject is so relevant to our region. As you see, the region is actually a catalog of the protracted emergency, mainly due to conflict in several countries in the region, like Iraq, Syria, Sudan, Somalia, etc. And that's why we have a specific focus on this approach in our region. Uh, the answering this question that actually what is the Nexus approach, we need to why it is not a new subject, and the story in the literature goes back to 1990s, but that was in World Humanitarian Summit in 2016 that the humanitarian and development actors and stakeholders committed to a new way of working that aims to meet immediate humanitarian need while reducing such need over time by adopting the triple nexus, humanitarian development, peace nexus approach, and leveraging the comparative advantage of these actors and working over multi-year timeframes to achieve collective outcomes that will explain what are they. And as mentioned, not a new story, it builds on previous initiatives such as EU linking relief, rehabilitation, and development initiative, resilience approach, conflict sensitive approaches to development and humanitarian assistance, and early recovery approach to humanitarian programming. In EMRO, to actually have a systematic approach to institutionalizing the Nexus, we have developed a Nexus style program, as I mentioned, is under a unit called Health Systems Emergencies Lab, and we try to answer these questions. To, what is that, how can be implemented, and how can be monitored or measured. So, and we developed a plan of action, and you see, to conceptualize, operationalize, and document and monitor. And with having these, we embarked on developing a guide for implementation of the Nexus for Health that is in final stage of the work and will be released soon, hopefully. We are working with the country offices and also partners at the regional level on technical cooperation, facilitate joint efforts, and etc. And to document and monitor the Nexus approach at the country level, we are working on development on country-specific profiles, such as the one that you see on the slide for Somalia. We are working to develop for 7 other countries in protracted emergency situation. As you know, basically the Nexus approach is already being taken in countries in our Eastern Mediterranean region and also other countries, while may not be conceptualized or formally labeled as Nexus. For this purpose, we use a term called Nexus style activity or initiative that is a health-related activity that contributes to identified objectives of at least two of the following fields, humanitarian development, peace, with the aim of advancement of UHC and health security and other related SDGs indicators. And there are many examples. Enhancement of the health information system in Libya, a strengthening trauma care program in Afghanistan and Palestine. The famous World Bank funded project in Yemen called Emergency Humanitarian Nutrition Program being implemented by WHO, UNICEF, and collaboration with the partners. So there are many activities and initiatives under with Nexus style that can be considered for this discussion. Like any other approach and program, it should follow some guiding principles that are listed here for the Nexus. First, to make sure that we don't harm, bridging the divide, integrating the approach as much as possible from the beginning of the emergency. We consider the localization agenda, and we need to ensure conflict sensitivity and peace responsiveness in whatever we are doing. To operationalize the approach, basically there are some elements that are listed here, can be done in iterative process. However, considering the specificity of the country and the setting. And these elements are establishing coordination mechanism, joint assessment, agreeing on collective outcomes, joint multi-year planning and implementation, harmonizing financial resources, and also monitoring and evaluation. How these elements can be implemented, for instance, under the coordination mechanism, what is important is that when we discuss about the health, we should consider that is actually part of a wider Nexus process that in the country, the emergency country is being led, for instance, by the resident humanitarian coordinator. We need to build on existing coordination structures, including health cluster and also health sector development forums and related platforms. Use existing frameworks such as, and mainly, humanitarian response plan and also United Nations cooperation framework. It's important to make sure that this Nexus that is about the bridging is functional, and these three actors, specifically the humanitarian development, actually work closely together. For this, it's useful to have a focal point or a team of focal point that map the health sector actors and activities, develop a Nexus strategy to define the way that this bridging can be done at any time point of the emergency, and for sure do the necessary capacity building. For the joint assessment, considering the different type of the emergency and settings we have, we need to basically be flexible in taking the appropriate options. That we introduce three approaches that include integrated, semi-integrated, or non-integrated. The first one is the ideal one, however, is the most difficult one to be done. We are trying to implement a kind of integrated assessment with all the partners in Yemen, but is an ongoing work. In most of the time, the non-integrated approach with triangulation methodology can be used to bring all the different sources of the information to inform the next step, that is defining and agreeing on the collective outcomes. That actually is a element that at this stage, or a stage that we formulate the SMART objectives that target progress toward UHC, health security, and health-related SDGs, are context and emergency specific and achievable in 3 to 5 years. It's very much important to make sure that our planning cycle actually is beyond annual basis. And for this, we either need to come up with a single combined plan covering all the needs, or work through the HRP to cover, to make it multi-years and aligned with the development plans. For harmonizing resources, for sure, again, according to the context, there are different options that can be pursued to have multi-partner and multi-year financing by donors and coordinated allocation of resources among health sector partners. Multi-partner trust fund can be an option. And for the monitoring and evaluation of the Nexus specifically, we should actually distinguish this one with the monitoring and evaluation of the specific programs. Actually, with the monitoring and evaluation of the Nexus, we mean monitor the process and functionality of the Nexus, make sure that this bridge between humanitarian development informed by the peace analysis is functional, and finally evaluate, monitor, and then evaluate progress toward the collective outcomes. Having all this said, basically, we have two key questions that I would invite the panelists to share their opinion and wisdom on those. First, how can the Nexus approach be operationalized? What are the opportunities and the challenges? And second question is, how has the approach been leveraged for response to the COVID-19 pandemic response and recovery? If I may, I would start with Dr. Abad Mataria, and each panelist will have 4 to 5 minutes to reflect on the questions, and after that, and in the meanwhile, again, I would request the participants to share your comments and questions in the chat box. Dr. Mataria, over to you, please.
Thank you very much, Dr. Ardalan. It's a great introduction to that topic. It's a very important topic, as you mentioned, for our countries of the region. So again, my name is Abad Mataria, and I'm the director of the Department of Universal Health Coverage and Health System, working at WHO EMRO. And in my reflection on the two questions that Dr. Ardalan has raised, I will take a health system perspective, and I would like to illustrate how we can leverage this concept or this approach of humanitarian development peace nexus in order to build the foundation of future health system. So let me start by reiterating what Dr. Ardalan mentioned about this concept not being, it's a sort of a new but old concept that has been there. I mean, it goes back to this principle of doing no harm. So the question is how, through our response for any emergency, we will be doing no harm for the future development agenda of the health system, but also through this response, how we can put the foundation for establishing a more resilient health system. I mean, it's unfortunate, or maybe this is how things have evolved over time, that the paradigm that is being used from a humanitarian perspective has been somehow different than the paradigm that is used by the development agencies or people working on development. And this has created a sort of a disconnect between the two approaches, which might have been the reason why the world has tried to find a way to operationalize, a way to connect these two paradigms. However, if one looks deeper and going to the essence of the method, you would find that the principles and the goals from these two approaches are very similar. I mean, what we want is to improve the health of the population. What we want is to satisfy the needs, including the non-medical needs of the population, and what we want is to assure social protection and financial health protection. So for me, if we look at the question of operationalization, it is how, through a response to an emergency, and whether it is a man-made one, whether it is related to a pandemic or to an outbreak, we put the foundation to recover the health system and to build a more resilient health system. I like very much what you introduced, Dr. Ardalan, but for me, the way that we have looked at the operationalization was mainly through the mechanisms that could be put in place to allow for that interaction. In addition to this, could be that how through this operationalization, we really can bring in structures and put the foundation for a better and more resilient health system in the future. If I link that with the current pandemic that the world is living through, we have been now calling for what is came to be known the step 0 in health system strengthening. So these are things that we didn't look much at in the past when we were talking about health system strengthening. These are issues that are related to the public health, to the essential public health function, issues like surveillance, emergency preparedness, issues that are related to the health protection and health promotion. So if I would like to reflect on the question of the operationalization, so I would take it from that perspective, saying that how through a response to an emergency, we want really to go back and to invest in the essence of public health, the essential public health function, which would be the foundation for building a more resilient health system for the future. And my last comment in this context is that this current pandemic, has shown us how our health systems have really failed the intention for which they have been established, and how through looking at bringing together the goal of universal health coverage, which has been the focus of health system strengthening agendas for the last almost decade, maybe longer, how to bring in an agenda of health security along with the goal of universal health coverage. And for that matter, the operationalization could be by integrating those essential public health functions along with the classical health system components, being governance, financing, health workforce, service delivery, and information. So this is how I would look at the question of the operationalization and the linkage with the current pandemic. Again, thank you very much for that question. Back to you.
Thank you so much. Thank you so much, Dr. Materia. Actually, great point. And then basically maybe in this classic grouping of the operational elements we have, maybe the point would fit very much into the collective outcomes. So basically it's important to how to define the collective outcomes to ensure that those public health functions, for instance, are strengthened. And thank you so much. Dr. Brennan, over to you.
Thanks, Ali, and good afternoon, colleagues. Great to be with you. Maybe I might start by just reflecting on why we need this type of approach, why we need the Nexus approach. In our region, which covers 22 countries going from Morocco and Northwest Africa as far as Pakistan and South Asia, and includes Somalia and Djibouti, 22 countries, 11 of them have ongoing crises. We have over 43% of the people needing humanitarian assistance globally live in our part of the world. And we have 8 major humanitarian crises ongoing, several of which have been going on for over a decade, such as Somalia and Afghanistan been going for several decades. And we have 2 of the 3 largest humanitarian crises on the planet in terms of people in need. In Yemen, the crisis there started in 2015, 24 million people needing humanitarian assistance, still 5 years later. In Syria, 3rd largest humanitarian crisis on the planet, 8 years after the start of the conflict, or almost by some people's estimates, 10 years, 11.7 million people still needing humanitarian assistance. So clearly, in these kind of contexts, the humanitarian model just isn't enough. We can't just be working on life-saving approaches. We need to progressively address other health needs, non-communicable diseases, and mental health, and so on and so on. And we also need to lay a foundation for longer-term health system recovery, health system resilience, as Ali and Awad have said. So this is why we need these crises that have been going on for many years. And I think Ali and Awad have laid out some good principles and practice for how to operationalize. And I think that the theory stands up well. I couldn't improve on what's been described, but I think that what happens in the field oftentimes theory runs into practicalities and field realities. So I thought maybe I'd share a couple of examples. One where I think the Nexus is struggling, and another where the Nexus has shown, some promise and impact. So let me start with Yemen. As I mentioned, a civil conflict that started back in 2015, over 24 million people in need of humanitarian assistance. The World Bank came in with this project, Emergency Health and Nutrition Program, where WHO and UNICEF partnered with the bank. And the goal there was to progressively expand access to a minimum service package to upwards of 3,000 health facilities, including primary healthcare, where UNICEF took the lead, and WHO at secondary and tertiary healthcare. And there are a lot of the classic inputs that you might imagine: supply chain, fuel, water for health facilities, training of health staff, payment of health providers, because the government just didn't have the capacity to pay healthcare providers turning up in the health facilities. And I think things progressed reasonably well in an incredibly difficult operating environment, such that that program was able to show some significant impact. Important indicators such as consultation rates, case fatality rate associated with the massive cholera outbreak, recovery rates from severe acute malnutrition were all within international standards after a year or two. And I think that reflects well on the approach again. And so the next phase of the project, if you like, was going to focus on not only coverage, but more on quality of care. It was going to focus on building capacities of district health teams to improve the governance. And it was going to expand the minimum service package. But this is where we run into problems. There's a divided government. The ongoing insecurity in Yemen, there's over 40 front lines right now. Divided government, poor governance, obstruction of aid, diversion of aid, lack of strong partners on the ground. And in fact, donors have lost trust and starting to pull back a bit. So we are not, and in fact, WHO, our program is going to be contracting there for a combination of all those reasons. So while I think, again, there was, the project was well conceptualized, it had a trajectory, progressive expansion over time. These are the kind of realities: the insecurity, the poor governance, the political divisions, the lack of capacities, the majorly disrupted health system. This is where we run into problems. Let me compare that with another experience that I had over 10 years ago in Liberia. In 2005, there was a legitimate peace process after 14 years of civil war. A popularly elected government came to power in 2006, and the government, together with donors and partners, developed a 5-year transitional health plan. Now, you can say, well, it was post-conflict because there was a legitimate peace process. But however, there were still big risks for escalation of violence. There was still 17,000 international peacekeepers on the ground for a population of under 4 million people because they were needed. And it was, like at that time, one of the 2 biggest peacekeeping operations on the planet for a relatively small population. But there you had a different situation. You had a popularly elected president who had the trust of international donors. You had a very strong Minister of Health who had a good vision and brought on board the expertise that he needed to develop, quite frankly, a visionary national health plan and policy, which included initially the transitional plan included a progressive downgrading of humanitarian assistance and a progressive upgrading of longer-term development support through a contracting out process. And that project, again, was able to document very good impact. Just about every health indicator that was mapped over the course of that transitional health plan went in the right direction. The only one that did not was maternal mortality. And my own view is it probably maternal mortality didn't progress as well, most likely because the baseline was probably underestimated. But, and again, what was the secret there? good governance, security, donor trust, strong partners. We don't have much of that on the ground in Yemen today. So these are some of the ingredients that I think are absolutely vital if we're going to really achieve some of the objectives of the Nexus. I know I've taken a bit of time. Let me just quickly respond to the other question. What about the Nexus and COVID? I think, you know, every good emergency, we want to create an opportunity out of that. I think we can do that with COVID. The Global Preparedness Monitoring Board estimates that the COVID pandemic has already cost $11 trillion and may cost another 10 trillion. As opposed to that, we want to invest in good, solid preparedness and health resilience, and in a global investment around $40 billion. So, you know, I think that governments, ministries of finance are going to finally sit up and pay attention to what's required, to what's needed in terms of investment in health systems, what's needed in terms of health resilience, as well as all hazard emergency preparedness. So I think there are going to be opportunities for us moving forward. Thanks a lot. Thanks for the opportunity.
Thank you so much. I appreciate and your emphasis on that. Finally, whatever we say, we need to operationalize that at the field level. So conceptualization is good, but finally we need to do it. And thank you so much for all the practical examples you provide. And I'm sure there will be questions from the participants in that regard. Dr. Shankiti, over to you. And so you have the experience of the Lebanon, Sudan, Afghanistan, and a lot more. But so how do you see the implementation of the approach at country level? Over.
Thank you, Ali, and good morning, good afternoon, and good evening to all panelists and all participants. I would maybe focus on Lebanon, and I will focus on Lebanon plus COVID, because I think there's a lot of good examples that are happening currently in Lebanon. I think Lebanon is a very good example for HDPN. For the reason is that Lebanon was classified as a high middle income country. And since October last year, I mean, multiple crises have hit the country so hard. So we have two mechanisms or two methods that are moving hand in hand. So as I said, I mean, since October, we had the civil unrest, and then we had the economic crisis, and then we had COVID and the lockdown, and we had in August the Beirut blast. And the country has been facing a huge burden because of the refugees. I mean, the country is hosting more than 30% of its population as refugees. And I mean, imagine with the COVID, it's quite heavy. I mean, in terms of the health system and its ability to cope. So if we look at the health system in Lebanon, we have pre-structural weaknesses in the health system. And specifically, I mean, it is highly privatized. And it has high cost, high technology-driven curative services, and there's limited capacity in the public sector. There has not been a lot of attention to the public sector, and specifically in advanced care. And there has been a lot of migration and drainage of human resources. And also, I mean, the quality of care, it varies from one facility to the other. So in terms of what guided us, what was the guiding principles for us to move forward in such a complex situation? First of all, we always intended, and from the beginning, from the start, we intended that the humanitarian and the development work will go simultaneously together. So, I mean, there was always the thought that whatever we do as a humanitarian response will have this transition towards an early recovery or a development arm. So we try to balance the support to immediate humanitarian needs and also longer term investment needs to address systematic causes of conflict and vulnerability. And we were looking at poverty, inequality, and lack of functioning accountability systems among the different institutions in the health system. So these were the most identified risks that we had been looking at in order to be able to address them using this approach. So we were looking for a more sustainable, more appropriate, transformative response, and looking at how we can nationalize the support, emphasizing on local leadership, capacities, development of national and local systems to accountably provide essential social services. So what was the prerequisites that we adapted for us to be able to implement the HDPN, or this transition from humanitarian to an early recovery nexus? The stakeholders and the main partners, they must have open dialogue, and we were trying to ensure this from the start on how best we can use the resources, the local and international resources. So there has been consensus building exercises that was done we were the convening party, but it was done with the UN, with partners, with NGOs, civil society, among the government, among different stakeholders. There was new partnerships that was also added to the whole spectrum. And we were looking at the co-creating and communicating complex ideas. We were looking for ideas that were outside the box, and all of this using system thinking, how we can move forward from a humanitarian to transition towards an early recovery. So there has been joint tools that were developed by all of us, joint analysis, joint language, and we try to ensure that the views of people affected by crisis are also integrated. We try to take community perspective in our planning for us to be able to move forward. So all of this, keeping this in mind. WHO has started the whole exercise by ensuring access to the care pillar under the COVID-19 response plans. So there was immediate access to certain areas of care, but there was also the thinking of a longer term perspective. So there was a need to support upgrading public hospitals, which there was an immediate need, but there's also a longer term need. And this is where we were looking at balancing the system. The system is highly privatized. 80% of the services are provided by the private sector and 20% are provided by the public sector. So it was an opportunity for us to have an equilibrium, or to balance this inequity between the public and the private sector. So the support to the public sector included the immediate support, in terms of PCR kits, human resources, but it was also upgrading and improving the laboratories, improving the ICUs, improving the regular wards that are now treating cases of corona. So these were areas that we focused on in order for us to increase the level of care in these public sector. And currently, more than 70% of the cases of corona are treated in public sector, not in the private sector. That is because of such a strategy that was adopted by the Ministry of Health, and with the support from the international community and the government. Of course, there was maybe also to talk about the immediate needs, which was directly addressed towards refugees and migrants, because we were looking at them as part of the whole, as part of the whole population living in Lebanon. So we had one plan for all, and this included them using the existing services that were open for Lebanese, the same as it is for Syrians and Palestinians. So the same testing strategy, the same surveillance strategy, the same isolation strategy, the same case management strategy, with the same criteria for admission and discharge from hospitals. So this helped us in, first of all, building the confidence in the public sector. And second, it helped also to operationalize the public sector for it to be more active in addressing the needs among the community. Just to let you know, because of the financial crisis, the current system and the private sector have not been able to be very active in responding to COVID. Because of the dollar business and the inflation in the costs. So they were not able to address or accept any cases of COVID specifically cases of COVID that will need ICU and will need advanced care. So all of these services now is provided through the public sector. And I strongly believe that such a move will, first of all, upgrade the public sector and allow it to be more active in addressing the gaps and the shortages, and at the same time having this balance between the public and the private. What is really important, and another example of where we were trying also to look at a humanitarian perspective, but also trying to move it towards an early recovery business or a modality. We were looking at the EMTs, the emergency medical team concept, which is flying in international teams from abroad for them to provide services in the country. And this happened when we had Beirut blast, and there was more than 11 emergency medical teams that flew into the country to do trauma care. But when they arrived here, they found out that all the trauma cases were dealt with and there was no need for additional support. So some of them repurposed for COVID. But the thinking is that these are international teams. They will be here for a month or two and they will leave, they will not stay. So what is the alternative? And this is where the concept of nationalizing such an approach would help us in first institutionalizing it and making it more sustainable. So what the thinking is to have what we call a twinning approach between the public and the private. So we are hitting here two birds with one stone. So what we are trying to do is to establish this public-private partnership where teams from the private sector will be twinned from the private hospitals will be twinned with the public hospital teams. First of all, they will provide the coaching, the mentoring, and the monitoring of how the operations are ongoing in that public sector, in the public hospital, and also will increase the knowledge. So there will be a lot of knowledge transfer. The second is that the private sector were not very keen on accepting COVID cases in their hospitals. So this is something that also worked to their benefit. I mean, they were ready to support the public sector with additional teams that can help them in moving forward with treatment of corona cases, but at the same time maintaining their facilities for non-COVID cases. So this is where you have at least an assurance that for non-COVID cases, you will have access to services in the private sector. And also for the COVID cases, you will have a place for ICU and non-ICU cases. So it was a win-win situation for all. This is a project that has been initiated, has been launched, and I'm sure we will be able to report on impact very soon. But there's a lot of enthusiasm among different parties, which is the private and the public and the Ministry of Health, on how this can move forward. So in our perspective and what we have been trying to do, and it's very interesting, Ali, that you mentioned EU and you mentioned the different donors. We have different donors that were very new to health and in Lebanon, and they have supported this initial support and the transition. And I would like because you mentioned EU, initially EU, we had this EU Madad program, which has been going on for a long time. Some of the funding has been repurposed for immediate support, but the remaining funding is also supporting the health system resilience and the continuation of care. So you can see that also donors are looking at these different perspectives and trying to make sense of what needs to be done now and what can be done in order to improve access to care on a longer term. And I mean, I can name several donors that have also supported this approach in Lebanon. So what we have been seeing as a result of our approach in terms of improving access and improving and having this approach of humanitarian versus early recovery and recovery. Well, first of all, equity has improved in terms of vulnerable population, the most poor Lebanese, the uninsured, the migrant workers, the refugees, all of them have access to timely quality care. the sustainability, what we are aiming for as a group, as an international group, as a UN and all stakeholders, is to ensure that there's a sustainable quality of care. So there has been improved in standards of care, improved in competencies among healthcare workers. Sustainable financing, because the funding is not simply humanitarian, it's humanitarian versus early recovery. So it's a longer term funding, it's a longer term commitment. So this helps us in having these plans, which would move forward in not only in 6 months we have to implement and then leave the facility. It gives us more time to ensure the sustainability and resilience of the program in these facilities. And last but not least,
that is very crucial. And that is very crucial.
Last but not least is helping us in reducing social tensions. It improved social stability, and there was it improved. I mean, less competition, because competition among different partners is not going to help. So it helped us in reducing competition, specifically for scarce resources. And there's a progressive rebuilding of trust between providers and users of healthcare, and improved transparency and accountability at government level. So this is our experience in Lebanon. And of course, I mean, any further details I'm ready to provide.
Thank you so much. Thank you so much. Lebanon is like a the Nexus style initiatives, and thank you so much. And the last point regarding the two last points regarding the sustainable financing, that's actually a key requirement for the Nexus success, and also the minimizing the tension as much as possible. And thank you so much, Dr. Katerji. So as a key health sector partner, so basically you have a lot of experience of this Nexus style work in different countries. Over to you.
Yeah, thank you very much, Ali. Good afternoon, good morning, good evening, colleagues. It's a pleasure to be on this panel and have an opportunity to share my own personal experience, but also experience of what and how UNICEF perceives this approach. I would like to focus on 3 things in terms of practical things to be aware of, based on my own experience, both in sub-Saharan Africa as well as in the Middle East. These 3 things are extremely important, and they, when we are considering the operationalization of the humanitarian development nexus, and they pan out in different ways in different parts of the world. Not because individuals and societies and communities are different, because the nature of the humanitarian crises and the underlying drivers of humanitarian crises are different. The first one is on commitment and coordination. For the nexus to be operationalized, this is extremely critical. And what do I mean by commitment? It's commitment not only of the stakeholders who are apparently seen at the front end of operationalizing it. These are the international NGOs, the UN agencies, the other parts of the UN beyond the humanitarian actors, as well as the governing authorities. A very important part is the commitment of the communities, a commitment of the communities themselves to be able to see beyond and to have the environment able to actually beyond the immediate humanitarian crises, as well as the response to see that today there might be a term that might not appear to be important now. So having a common understanding and a common commitment towards being able to move.
Excuse me, because you are
as we try to stretch that
up,
into the,
you may turn off the video, maybe help with the connectivity.
Yeah, I'm having my apologies, colleagues. There's been a lot of challenges with the internet here in my part of the neighborhood today. Is it any better, Ali?
Please.
Okay, so the the issues around coordination and being able to coordinate at some points in time within this nexus, really being able to coordinate with multiple people who are sometimes in some ways, and I hope I'm being politically correct here, are actually part of the conflict or are on the fringes of the conflict. So being able to have the commitment and coordination of all these stakeholders is extremely important. The second point is about the awareness of the needs of the community and awareness of needs of all the partners involved in operationalizing the Nexus. Sometimes the expectations and the narrative that might be out there is things are really, the community and the particular conflict needs certain interventions, but in reality, you will feel that what people need there are something else. We are trying to get them, healthcare services, trying to get more fancy hospitals, but what communities need at that point in time really might be access to sustainable and safe water and wash services, because that has an impact not only on the health, but on the other sectors as well. But a very important point and an important input into having good health and good health outcomes. The last point is on practical and measurable results. I think very, very important as we try to operationalize is we be very realistic in what is it that we are trying to achieve, both in the short term, which falls sometimes within the ambit of, I think, what Awad mentioned about the two different paradigms on what we are trying to achieve with the humanitarian response. The timelines that we look at, the time horizons we are looking at are sometimes at the most 12 months, sometimes even lesser. And really trying to merge that with development outcomes and development horizons and development funding streams and budget allocations that might be 24 to 36 months at minimum. So how do we have short-term results which are practicable and which are measurable? I will try to answer your next question, Ali, by giving an example of really how UNICEF is trying to work in the context of COVID in ensuring the continuity of health services. Clearly for UNICEF, where children and women are at the center of the work that we do and the center of the support that we provide to governments and other partners at country level, we saw very early on in the pandemic that essential health and nutrition services for women and children were declining at a very, very rapid rate. Of course, as was pointed out by both Rick and Awad, many countries in this region are already suffering from conflicts or other stresses to the system prior to COVID. So COVID is not the only stress that is coming in, or not the only stressor challenge that health sectors have to face. But we realized early on in April that immunization services for maternal and child health, antenatal, postnatal care, skilled birth attendants, and nutrition services for treatment of severe acute malnutrition, all of them were dipping, and they were declining at a very, very rapid rate. Of course, in some countries, for instance, in Yemen, in Libya, in parts of Sudan, this was already being exacerbated by existing weaknesses in the system. So UNICEF supported with what we call a jumpstart package, which basically puts together what we were already doing with the delivery of services, and add on 3 additional things. The first one was support to the health system on IPC, infection prevention and control, which again, working jointly with WHO and ministries of health, if I take the example of what we have been able to achieve or in the process of achieving in Iraq, is a really, really strong commitment from the government with support from both WHO and UNICEF to have the capacity building of the primary healthcare staff in the tunes of tens of thousands that could be trained quickly, that had to be trained in the context of where face-to-face meetings, training sessions, etc., were not possible to do, to add in really something that we do on IPC. And then seeing that in the longer term, in a region where it's surprising that a lot of countries here do not have minimum IPC guidelines, do not have minimum IPC protocols, was to be able to see this as an opportunity and transition this to include it in the standard of care for what a primary healthcare center should do. The second part was working through our colleagues. Again, we have IFRC and WHO on the panel here, working very closely with them on the work that we do on RCCE to restore trust of communities in the health system. How do we, all the messaging around was stay at home, nobody wanted to go anywhere near a health facility, because apparently that was where there was a very high fear of contagion, how do we then tell people that we could have to go back? They need to take their children. If they are pregnant, their women need to go and access antenatal care. So really working on capacitating the healthcare providers to build their interpersonal communication skills, but also large scale through both the media as well as social media. How do we improve trust of communities? This will again continue, recognizing that many of the countries in our region are very vulnerable to declining primary healthcare services. We have conflicts, we have many other natural disasters. We do see dips in at different times of the year, as well as in response to crises. The last point was really ensuring that everybody had PPE as part really of the IPC, but also ensuring that this was part of standard of care going forward. So again, Ali and colleagues, a practical example of how we have been able to move from a humanitarian response to what can go and pay dividends in a more developmental frame. Over from my side.
Thank you so much, Anirban. Actually, basically, great examples from also the UNICEF work and also the joint work that we are doing together on the strengthening the PHC for a UHC. That can be an excellent entry point for the Nexus operationalization. Okay, Dr. Jarboui, over to you. Thank you.
Thank you, Dr. Ali, and thank you everyone for giving the opportunity for me to be part of this panel. As I already shared, and our point of view from the Federation of Red Cross and Red Crescent, more than 192 national society that are supporting their local authority into addressing those challenges even before it came, as you know, Rick, and you are being in a lot of other crises, and Dr. Iman, she already highlighted before there is sign before crisis. There is always micro crisis or medium crisis that lead to the biggest collapse of the system, where the volunteer, the national society are there responding. I can name during the Lebanese port blast, the Lebanese Red Cross was the first there in a minute with their volunteer. More than 200 ambulances was mobilized. Before even the government, and let me be honest, maybe I will be not very political correct. There is less and less trust in the institution by the population itself, and that's why our focus is more on building the resilience of the community, on empowering the community with the knowledge, on supporting them with the right knowledge and with the right tools to be on of their decision and building their resilience with a people central approach through our network that are universal but also localized, that could help actually during the crisis, during the crisis, and after the crisis, to continue the work that international committee could come with, and also supporting most of the cases in most of the health system in the region that are sub-optimized, as Dr. Ayman shared, are heavily technology-oriented, curative-oriented, doesn't take into consideration preventive care, community engage within their what they want, to address their need. I remember during the beginning of the Syria crisis, people were not asking for trauma kit. People are asking for really NCD medicine. How I have my and even in Iraq also, how I can have the medicine for my father and my grandfather and mother and neighbor for diabetes, for the renal failure, but also how where they can find those elements. Unfortunately, crises are taking more and more longer. With the Syria crisis, more than 10 years. We in Yemen is not the only crisis that Yemen is ongoing since the independence. We see that building more the resilience of the community, being informed, risk informed through a holistic approach, addressing the determinant, focusing on preventive health, looking at the long term in terms of addressing wash need, accessing to water and sanitation, a proper hygiene, that help more the community to build back their resilience while waiting for the health system and governance to build the system. And we know currently through a lot of with the social media, information are being used and shared more widely, but also there is the other part of the information when the information is not trusted, where need more engagement with partner as Ministry of Health, WHO, UNICEF, to give them the right message through the trust that national society are gaining over years and years of collaboration with those community, because volunteers are coming from that community and they are expressing the voice of their community. And assuring the connectivity is there between different national society, but between different branches within the same country. Giving the same example of Libya, where access for most of the humanitarian actors are very limited, while the Libyan Red Crescent have access almost everywhere. The same for Yemen. Going to the financial part, crises are pushing people to poverty, and asking for more from the government, but also from other local partners and civil society to engage and to work together to reach that, the well-being of the society and the community. Well, I think the complementary from building back a system, a robust system, building back a robust health system, a resilience health system, but also building back the knowledge and building better the resilience of the community. I think that's where the Federation and National Society and the Red Pillar in general is working and could complement the other party, academic and the Blue Pillar, to achieve universality, achieve universal health coverage, where the last mile become the first mile. Thank you.
Thank you so much, Ayman. I appreciate it. Dr. Sondrop, it's over to you. From academic perspective, how do you see this discussion, conceptualization from the operationalizing, and the challenges and opportunities we have? Over to you.
Yeah, thank you, Ali, and thank you all for this rich comments which we have seen based on the initial presentation of Ali. And a lot still appreciate that you are doing this ongoing work on getting the Nexus running and getting it operationalized, following our pre-COVID meeting in Cairo earlier this year. And I've again been looking at the document, and I think it's clearly enriched. It's trying to be doing that operationality. So yeah, just a few remarks. I think you have said a lot, and time is running as well. So I do think that the word nexus is used a lot more. I mean, it's really have become one of the buzzwords these days. That's different from before. That's EMRO, but probably also elsewhere, which, yes, that happens with words. Does it mean anything? So you are really trying to operationalize. But I think the notion is intuitively right. I mean, people relate to it if you get an initial explanation. What it then actually is still to be seen. I think it gets more traction because of the COVID-19. That's so clear that people, humanitarians, development agencies, they need each other so much more, and it's also a bit less political, so it's easier maybe to collaborate. That's what you see. So that's one aspect. But I think it might also work the other way around, that by this push through COVID, it might also be easier afterwards to relate more easy with each other once COVID is a bit over. If not alone, by having much more emphasis on this kind of virtual meetings, which are to some extent helpful. I would like to share what I saw in a meeting last week, and there was a woman from UNDP, and she was participating in the meeting. It was also about the Nexus, and she felt it obviously necessary to say, okay, I want to pass on some myth busters. And she said the Nexus is not about joint programming. It's not about stretching humanitarian programs. It's not about overriding humanitarian principles. It's not about pooled funding. And it's not about Nexus projects. So, and she had a nice slide with it. So it went down well to participants. But I think what that makes, it's someone from UNDP, not from health as such. So two messages. She's also working on the Nexus in other sectors, and she feels, okay, this should be a message because people are obviously worried, I think. And that's also what you may come across. It also highlights the need to work multi-sectoral, which adds a layer of complexity to your model, which you have, which is already pretty complex. In particular, if to address the P of the Nexus, you need to have that eye open for other sectors and other languages, as it were. From that complexity, which we see, and often this kind of things result in more this high-level, bit abstract headquarter talk. I was also thinking about capacities, because you thought you want to raise capacities in countries, and that of course reminded me of our old endeavor from our institute, but instigated originally by WHO, to have these courses, the ADHS courses, which was more focused on transition from war into post-conflict, but I think it's also applicable, needs some adaptations for humanitarian development nexus. And I think the essence, what we did there, and still do, is also, we did it also in the EMRO context, to bring people together, because time and time again, if you meet people on the ground and you know a bit about the debates which have been going on at headquarter levels, you see that huge gap. And I think what it comes down to, people on the ground have to see the space where they can maneuver, because so many things do happen. You may have ground ideas, ground policies, but in the end, there's a lot of, for instance, donor dynamics, which influence what can do. And these are processes which you can hardly influence, but then you have to grasp opportunities, and people on the ground can do that, but they need those ideas. And by bringing people together from different ways of life, humanitarians together with people from the development side, from NGOs, from multilateral agencies, even donors, I think it's very valuable, and it's maybe we should consider to beef that up again. Such coursework, such capacity building, of course, also has to be driven by evidence, and that was the other thing, briefly to reflect on. Also in your document, you say, okay, you want to do the documentation, and you showed a nice monograph on Somalia. It's there, but I think we all know that this kind of processes are difficult to research. I think to do really, it's so many variables, it's very hard and long and not so attractive to research. And so typical PhD students may not go into that so much, but I think there is a high need for documentation. But you probably need to have to institutionalize this to some extent. Of course, we do the occasional systematic review, the occasional this, occasional that, but I think it needs a longer term effort and it needs some institutionalization, a framework in which you can do this. I just throw this in, but then of course I had the other example of yet another meeting yesterday where they were introducing a regional network of institutions for evidence and data and policy, which is a new EMRO initiative. And maybe that may be a house for creating this kind of evidence as well. I don't know. It's just starting, but it's just a thought which I came across yesterday. So I would like to keep it here because time is running. Ali, up to you.
Thank you so much. Let's work together to make the Nexus research attractive. How about that? Yeah. Okay. So thank you so much. So basically, we are almost done with the time. It's 5 o'clock sharp, and I keep receiving the messages from some of the 11 panelists that they want to leave, and also the participants. And of course, we have some questions that we wanted to ask. One of them that actually I would ask if you, one of you kindly just volunteer yourself to answer would be great. And the question is that how can financial fragmentation be prevented or reduced at least during the transition from humanitarian response to health system development? And the Secretariat kindly gave us more 5 minutes. What over you? I think yes, please.
Yeah, thank you very much for the very pertinent question, and it is valid for an emergency situation, but also for when we look at the fragmentation within different public health programs as well. I think the simple answer for me, from somebody with a background in health financing and economics, is to rely on public financial management systems and arrangements in countries. So not to establish parallel streams for financing and for disbursement of funds, but to rely on the public financial management systems in the country in order to bring that additional funding, which would be directed toward emergency response or for future development, to the larger pool that would be available and at the country level, and then for that money to be allocated based on the priorities of the country. That is the direct answer from my side.
Thank you so much. Thank you so much.
I can add to what Awad said, because what he said is very important. But it is important, Awad, also, because we are seeing it here. It's important to have a clear strategic document or vision that shows the transition from emergency to early recovery or development. And this needs to be used as a tool in all dialogue. I mean, with high level donors, partners, UN, government. It will unify the approach towards the implementation of this smooth transition rather than having a divide. So I just wanted to add this one.
Okay, so a follow-up question can be a subject of research. And who can potentially support that?
It could be, and I think some work is ongoing. I think that was work done under the flag of the UHC 2030 on this topic, and which was touching on this kind of things. How could you influence this kind of things, and how could you influence the fragmentation? And for me, it's always the big difficulty is you see this donor processes which takes years to then before the money is being released, and there's so many processes in between and internal donor restrictions and how to affect that's the big challenge. It takes it's a long haul in any case.
Okay, thank you so much. So if you don't mind, we can conclude the session here. with acknowledging that this Nexus approach is very challenging to be implemented. However, there are opportunities, a lot. And one of them is the global interest and the commitment to do that from both humanitarian side and development side. Okay, while both are challenged with the implementation, but this commitment and interest actually I think is the great opportunity we have, and we look forward to work all together, including the dear participants on this call, to move the agenda forward in our region and also beyond. So please stay in touch after the meeting, and let's continue this discussion. And again, thank you so much, Awad, Egbert, Iman, Ayman, Anirban, and the RIC actually unfortunately had another commitment that had to leave sharp at 5. And also Clara for all the kind support you provided to organize this session, and also the HSR 2020 Secretariat, and for sure the dear participants that participated in this meeting. Thank you so much and wish you all a nice day. Goodbye.
And thanks to you, Ali. Thank you, Ali.
Okay, thanks for organizing.
Thank you.